Coping with teen angst in a complex iWorld. This is part 4 of a 4-part slide program. Chapter 3, Pediatric Pharmaceutical Substance Abuse. I acquire quite a few medications and then dispense them to my friends as needed. I usually know what I'm talking about, said Ms. K, a 25-year-old who is not a healthcare provider. Now, this is an issue familiar to us all by now. Pharmaceutical substance abuse is now more common than illegal drug use, according to the National Survey on Drug Use and Health. These numbers have remained fairly consistent in the last few years. Now, this is a photo taken at a college library down the street from where I live in Cambridge. I did not take this photo, but it is an important photo that identifies this growing problem. Newspapers have informed the public of this increasing problem, and those who engage in this behavior seem to have little fear talking about it openly, as in this absolutely magnificent 2005 article from the New York Times titled "Young, Assured, and Playing Pharmacist to Friends." USA Today even featured this growing epidemic on its front page and described the increasingly common occurrence of farm parties, PHARM parties, also known as bowl parties. Now, at these parties, kids empty out their parents' or their own medicine cabinets into a bowl, pass the bowl around, and swallow the tablets one by one until they get a buzz or pass out. Now, I'm not surprised that bowl parties are so popular today because it reflects what people like most about these ubiquitous iPods. The most popular feature of the iPod when it was first released by Apple is the shuffle function. In fact, that feature was so popular it prompted Apple to release the iPod Shuffle, now in its 4th generation and in a variety of colors. Looks almost like candy. Fortunately, our government has begun studying the problem of legal substance abuse and issued public health warnings to clue in otherwise clueless parents. And there is an increasing body of published literature on this topic. This is a terrific paper, and the key word in this title is diversion, because that's what's happening. These are legal prescription drugs being diverted for illegal and abusable purposes. I thought this paper, published just last year, provides some perspective on what empowers prescription sharing and diversion. I want to blow up the introductory paragraph right here. The healthcare industry has witnessed a gradual transition from a provider-centered model in which patients are relatively passive recipients of care to a more patient-centered model that empowers patients as consumers of health services. This is exactly what the IOM suggests we do in this millennium, and their Crossing the Quality Chasm report. I think Ms. K would agree. She seems to be quite fond of the letter I and confident in her own judgment. She wants to be in charge. How informed that judgment is surely debatable. When I was in Chicago in collaboration with Northwestern and the Illinois Poison Center, we looked at some outcomes involving pharmaceutical substance abuse. We looked at methylphenidate, we looked at zolpidem, and we looked at caffeine supplements, and in all instances we were coming to the same conclusion. When these products were used in conjunction with other pharmaceuticals, more frequent ED visits occurred and more frequent hospitalizations were needed. Polypharmacy again seems to be a core problem. There's been so much written about geriatric polypharmacy. We need to be more thoughtful about pediatric polypharmacy, because this is a problem that is getting worse and worse, and of course these pediatric patients will become adult patients, and unfortunately this is a problem that we have contributed to by being so liberal with some of these prescription patterns. We're going to see this and coroner's reports more frequently in the years to come. This 17-year-old died from acute combined drug toxicity. Michael Jackson died just over a month ago, and it won't surprise me if his medical examiner's report includes this also as a contributing factor to his death: acute combined drug toxicity. So now we are back to the very first slide. The ED evaluation management of psychobehavioral emergencies has not changed in the last 10 years, despite significant increases in emergency department visits. Now, I do not have any suggestions on how we need to manage these patients better. The system currently in place seems to serve its purpose. Patients arrive, we do a medical clearance evaluation, and then we have our psychiatry colleagues determine ultimate disposition. However, I do think it is time for the emergency department world to tune in and pay closer attention to evolving psychobehavioral visit trends. We need to be vigilant when evaluating these cases that we are asked to provide medical clearance for, and we need to be vigilant for patients who arrive with a complaint of weak and dizzy. When we see these patients and we recognize certain patterns, we need to be inquisitive and ask why some patients come back over and ask whether or not the weak and dizzy patients actually have a medication as the reason for their weakness or their dizziness. Just last week, a student and I took care of a woman on 20 different medicines. She was started on an additional antidepressant by her primary care doctor the day before, so now she's on 21 different medicines. After the second dose of her 21st medicine, she developed weakness and confusion, and her family brought her to the emergency department for evaluation. She got a limited emergency department workup. We admitted the woman to reconcile her medicines. It would have been just as easy for us to admit her for the generic pre-syncope evaluation that would have included a lot of unnecessary testing and imaging like MRIs and CAT scans and even some LPs. Instead, we insisted the inpatient team to reconcile her medicines, discontinue that 21st one, and get the psychiatry service to reevaluate her current antidepressant regimen. And indeed, after a couple of days in the hospital, she improved. The psychiatry service slightly increased the dose of one of her existing medicines, and she was discharged safely. And that brings me to the third charge to the group. If we remain vigilant and we are inquisitive, we should not be afraid to speak up and mention what we notice to primary care providers or to the psychiatry service. We have a unique opportunity to get involved in some of the problem solving inside and outside of our emergency departments, because right now it is looking that the problem is only going to get worse, the volume is going to get higher, and we need to be involved in limiting the number of these patients coming to our emergency department, because they don't all need to be seen there, but they need to be taken care of. Now, this is a talk that used the iPod as a metaphor. Those of you who weren't in conference that day in Dowling will be asking for credit for these online programs. Here are 5 questions that need to be answered in order to gain any credit from listening to these programs. Question number 1. What is one example where the FDA has delivered an inconsistent or confusing message with regard to psychotropic prescription medications? Question number 2. What are some proposed reasons why medications are prescribed so liberally in this current millennium? Question number 3. What are some of the biologic reasons why antidepressants and other medications might work differently in pediatric patients? Question number 4. Did the FDA Modernization Act have anything to do with increasing psychotropic prescription rates, and if so, why? Question number 5. What are the reasons why medications were not systematically explored or examined in pediatric patients before this millennium? What specifically changed that practice? If you have any questions about these programs online, email mark.meisick@bmc.org. Thank you for listening.